Ladies and gentlemen, please welcome to the stage Foreign Policy's publisher and CEO, Andrew Solinger.
Good morning, everyone. There's some fantastic conversations going on. We're going to have some fantastic conversations on stage now, and more time to talk with each other. And I know there's several people still filing in, but we have a very jam-packed agenda, so we would like to get started. I'm Andrew Solinger. I'm the CEO and publisher of Foreign Policy, and I'm really pleased that you're here to join us today for a very important conversation on rethinking global health. We've got great folks in the room, an audience online of thousands, streaming worldwide. So we're really pleased to have you all joining us for this important conversation. And I'm just going to level set with some sobering points. We have declining donor funding and cuts to institutions like the WHO, and the global health community faces mounting challenges in its efforts to get to its SDGs. Global health is also strained by rising geopolitical tensions, financial pressures as institutions try to deliver more with less resources. So the future of global health and governance will depend on innovation, smarter financing, and partnerships. And we're going to talk about those today and how they will bridge the divide between governments, multilaterals, and the private sector. So disease elimination and creating equity in the most underserved communities is not just a medical challenge. It's tied to geopolitics. And that's one of the reasons that foreign policy, why is foreign policy convening such health programming as this? And that's because it's incredibly important that we work together as common humanity to solve these problems. We feel very strongly about that, and we're happy that you're here to join us in that effort. So, some housekeeping. There's a lot of stuff on your chair. Let me tell you about it. There's a QR code on your seat that will take you to the agenda. We want to make sure we conserve and not print too much paper. And one side, you'll click on that QR code, and you'll get to the agenda, speaker bios, and the like. You flip that over, and there's a QR code to subscribe to FP. One of the reasons we're able to do this is through your sustaining subscriptions. So please do. If you don't already subscribe, think about subscribing. A lot of the folks in the room I know already do have subscriptions. We have cool hats for subscribers. They say soft power on the front. Joseph Nye, the dearly departed professor, actually coined the term in Foreign Policy magazine in an article many years ago. So we're honoring him with those hats here today. We also have reporters on the ground here in New York. They are publishing their SITREP newsletter, Josh Halterwanger and Rishi Iyengar, daily, focusing on all the scuttlebutt happening around UNGA. You'll find instructions on how to access that and sign up for it in the great tote bags that help you think globally. And also, there's some headsets on your seats. That's not for you to zone out and listen to an iPod or music. We're going to have a discussion in a couple of hours that will feature Brazil Portuguese. So we have some specific instructions about that. I think you all know how to use a translation device, but really we want to collect them afterwards. And my colleague, Dr. Maisha Alam, who heads FP Analytics, will explain that a little bit more later when that part of the program comes together. So I think that's it for the housekeeping. But I want to thank our partners. Today's event was made possible with help from the Gates Foundation, Merck, and the Rockefeller Foundation. You can applaud. I think that's very deserving. With additional support from AstraZeneca, Bupa, Cigna Healthcare, and Seed Global Health. Thanks to them as well for supporting the program. Lastly, I am super excited about a brand new foreign policy podcast, which we are just going to start work on. It's focused on where global health could be headed at this moment. And the conversation you're about to hear is actually going to be part of that podcast, of that first episode. That means you're all going to be part of that first episode. So let's get going.
Please welcome Waki Health Executive Director, Dr. Rosemary Mburu, and Gates Foundation CEO, Mark Suzman, for a conversation with journalist and broadcaster Henry Bonsu.
Are you ready? Yes. Do you mean it? Yes. Fantastic. Thank you very much indeed. It's great to be here. It's great to see you all. The Threshold is a new foreign policy podcast about how to end infectious disease in today's world. In this first episode, I'm delighted to introduce Mark Sussman, Chief Executive of the Gates Foundation, and Rosemary Mburu, Executive Director of WAKI Health, a leading African advocacy organization based in Kenya. And over the next 25 minutes, we'll discuss the future of disease elimination. We've never been closer, but also the challenges have never been greater. Let's start, and I'm a journalist, we'll have to start, with some breaking news from this morning. Gates announced a partnership to expand access to generic lenacapavir. Now, Mark, tell us about... Do I have to take it from the top? I can rewind and come again. I can. Mark, tell us about lenacapavir and why this is so significant.
Yes, well, the excitement we have about this drug, lenacapavir, is it's something that is essentially 99.9% effective at preventing HIV. And it's a 6-monthly injectable developed by a company called Gilead. And our announcement today, which we've made in parallel with an announcement that's been made by some other partners, including the Clinton Chai Initiative, the UNGA80, is to be able to develop that drug with partners in generic manufacturers in India that is going to make it available at $40 a dose. Currently, it's available in high-income countries like the US for many thousands of dollars. And so what this is showing what's actually possible, the kind of pipeline of innovation we have in global health, transforming a disease like HIV/AIDS. And so we've made that announcement on the heels of an announcement we made earlier this week as well, which was our commitment to the Global Fund to fight AIDS, TB, and malaria, where we've committed $912 million to their current replenishment, because partnerships like that are key to actually make sure that tools like the new lenacapavir generic are going to be made available and affordable for people who most need them. So we want to show progress is not just possible, it's happening. Progress against these diseases is real, but it needs much more energy and commitment.
Brief supplementary. How much of a... Yes, thank you. How much of a game changer could this be?
It's a huge game changer because of the cost effectiveness and the actual clinical effectiveness, the fact that it is nearly 100% effective. And so it's not going to be transformative initially, but when you add it to a full program of HIV, when you're combining prevention and treatment, and ultimately we haven't given up all the R&D on a cure, which we still are optimistic we will get, that is a pathway to something we hope by the end of the Gates Foundation's lifetime, and we've announced earlier this year that we will be closing our doors in 2045 because we are making a historic commitment to spend $200 billion between now and then with a vision of ending the scourge of infectious diseases like HIV, TB, malaria, and polio by that deadline. And a tool like this is an essential one to get on that pathway to disease control.
Thank you, Mark. Rosemary, I'm wondering whether you're just as excited about this development from where you're sitting in Nairobi and traveling across Africa and putting pressure on the likes of the World Bank, the IMF, and other organizations as an advocate. Does it seem just as powerful to you, or do you have other concerns?
It's absolutely powerful, and it's amazing. I sit here and I reflect back on the journey we have come, and the fact that we can have intervention like lenacapavir and have it be rolled out simultaneously in high-income countries as it's been rolled out in LMICs, it's amazing. I think this deal, and thank you to the foundation and all the partners that have come together on this deal, I think places LEN as perhaps the first tool, the first intervention where we're going to see equity in terms of rollout in both high-income countries and LMICs. And I say this because...
When you say LMICs, you're talking about...
In low and middle-income countries. Yes. So basically, I'm from Kenya and other countries where we have always been the last on the queue to actually access scientific discoveries. So deals and progress that can actually ensure that we put that, people in LMICs and high-income countries and roll out products at the same time is very important. And I also say this because we are at a very critical time. I just look back to where we've come from. I mean, growing up in Kenya and coming of age in the late 80s into the early 90s, where HIV epidemic was ravaging communities, where also science was just emerging. but also where, in many countries like Kenya, we were going through structural adjustment programs, which made it difficult for our governments to spend on health. And then later on, towards the late 90s, a country like Kenya in 1996 started accessing ARVs, but it was only for the rich. I mean, people couldn't afford that. And so having a product that works and people could not access, I think we have many lessons learned. And to where we are now with the kind of global solidarity that we are seeing, the way science has grown, and then putting equity at the center of that is exciting.
Mm-hmm. We're talking about lenacapavir, but there are other scientific developments which you may be aware of that you're very keen on and that you want to see get down to the last mile, to the people that you're talking about. Which other areas are you very keen to see more development in?
I think in terms of ending infectious diseases, and in particular HIV, TB, and malaria, we have seen progress. We have seen in malaria, we have 2 vaccines, but also we are looking at seasonal interventions which are working. We also look at TB. The sector, the field has come a long way. We are talking about more affordable diagnostics. We are looking at shorter drug-resistant TB treatments. We are looking at, even within HIV, an arsenal, a toolbox of other interventions, with LEN really being the most exciting at the moment because of everything that has happened. But for TB, for HIV, for malaria, there has been movement in the right direction when we come to scientific discoveries.
Tremendous. Thank you, Rosemary. Mark, what does this tell us about the potential for a future in which infectious diseases like HIV, malaria or TB can genuinely be eliminated? Because we keep hearing about AI and all the potential. Bill Gates was talking about this at the Goalkeepers event on Monday and people are getting very excited. Can it really happen?
The short answer is yes, it absolutely can happen. And we're determined to help make sure that it does happen. And that is the core goal. When we announced our 2045 target, it has 2 core goals that it sets. The first is that no mother or child should die of a preventable cause, and nobody should die of an infectious disease, like the big scourge of the infectious disease of HIV, TB, and malaria, the 3 big killers, and malaria especially a killer of children. And both of those goals are broadly possible, and we've already seen tremendous success. It's often not understood how huge the progress has been between 2000, which was when the Gates Foundation was founded, and today. We've seen a halving of deaths in HIV, in TB, and malaria. But that still means there are way too many deaths. We still have 1.6 million people dying of TB every year. It's the infectious disease that kills more people than any other. We have 600,000, the vast majority of them dying of malaria. We still have 1.4 million new HIV cases every year, which is where tools like lenacapavir begin to be so critical. But with the pipeline of innovation we have, and you've just heard some of those tools from Rosemary, we're in the process of investing many hundreds of millions of dollars in what would be the first new tuberculosis vaccine in over a century, which is currently under trials in Africa and Asia. And we will know by 2027 whether that vaccine works. And if it does, it could be transformative against this disease that has plagued humanity for tens of thousands of years. And similarly in HIV, we are trying to combine all of those tools, the prevention for those who don't yet have HIV to stop them getting the disease, the treatment for those who do have HIV so they can live healthy, disease-free lives, and ultimately the cure, and we hope a vaccine that will stop anyone worrying about HIV in the future. And so across all of those diseases, we hope that by 2045 and for the generations that come after, these will be things for the history books, that people will tell their stories about the diseases that used to exist, like malaria, like tuberculosis. And that is our goal and our commitment.
Thank you. Rosemary, Mark talks about these diseases as being something that children in 2045 will read in the history books. How realistic does that vivid and optimistic scenario seem to you?
Yeah, so an optimistic scenario is, I imagine a world where we scaled up these tools, we scaled up this innovation, and that will take being intentional in terms of delivery and in terms of financing. And one of the things that has inspired me during this week is like the goalkeeper's theme, don't stop at almost.
Yeah.
And then also the Global Fund replenishment communication, where we are saying stop at nothing. And we are so close in some ways, but also conscious that the diseases are not at the same level in terms of making progress towards, ending as a public health threat. And also acknowledging that countries are not at the same level. But if you look at the Global Fund results report that just launched a few weeks ago, we are looking at some countries. If you look at Kenya and TB, if you look at some countries like Cambodia and HIV, you can see that some countries are actually almost, when you think about 2030 targets, and some countries actually are ahead of the global target pathways. But for those countries to actually push to the last mile, we need more now than ever unprecedented global solidarity, more now than ever investments in financing, but also thinking about delivery, multi-drug dispensing, innovations like LEN, and how then we translate the science into public health impact. But we have come so close, but also we need to think about some countries that are struggling. The story of malaria is one where you have countries that have actually eliminated and made progress, but you also have countries where they are springing upwards. So just thinking about the differentiated approaches, but yes, I think I'm optimistic about that.
Yep. And Rosemary, you mentioned the replenishment a moment ago, and the clock is ticking rather loudly down to the all-important event happening on the margins of the G20 in Johannesburg. The Global Fund to fight AIDS, TB and malaria is going to be asking the world to come together again and to pledge for, I think it's the 8th cycle, isn't it? How concerned are you that people aren't listening today as they used to before? And what is your tactic as an advocate to make sure they do?
Yeah, I think as an advocate, we have a story to tell of the progress we have made. The scientific discoveries that we've made also actually mean that in our narrative, we have come a long way, and we really need to double down on investments, which mean that for now, the Global Fund is perhaps one of the best global health investments. And since we are talking about the replenishment, what the $18 billion US, which is the target for the replenishment, is giving us actually is a lifeline, for communities. I see the $18 billion US not just as a target, but actually as a lifeline for communities, people whose lives will change because of the new innovations, because of the investments, because of how we invest in the delivery, but also because the potential that this investment has in terms of saving an additional, up to 23 million lives, averting about 400 million infections across the diseases, reducing mortality, combined mortality across the 3 diseases by about, 64%, is really a story of the future that we want, where we are so close to that. But also the fact that this replenishment is being co-hosted by the governments of South Africa and the UK is also a story about Africa's leadership. And that is something that I think the world needs to come together to support. So even though we haven't seen this amount of, dramatic shifts and politicization in global health, I think the Global Fund replenishment and us being successful in that is a great entry point to actually turn things around and to help scale up the innovations we are talking about. And by the way, Mike, thank you and congratulations to the Foundation for pledging to the Global Fund.
Yes. Yeah. In radio terms, you would call that a segue, because I was coming to exactly that point. $912 million US. Bill Gates announced that at the Goalkeepers event on Monday night. I was privileged to be there in the room, as you were, Mark. How crucial is this investment in the current context, and why has the Foundation kept the faith with the Global Fund?
So we've kept the faith because, I'll remove the perhaps from Rosemary's comment, as the Global Fund is the most successful life-saving initiative of the 21st century by far. It has saved over 70 million lives to date over its 23 years of life. That's an extraordinary achievement, and it's done so in an unprecedented way. It's crowded in philanthropic resources, private resources, governmental resources, pooled them together, driven down the costs of bed nets to prevent malaria, of antiretrovirals for HIV, of treatments for tuberculosis, and it keeps doing that. And that success story, I actually worry the world has become almost a bit jaded and used to, and doesn't really internalize how profound that is. 70 million is almost too big a number. It's abstract. And trying to bring it down to the very human level, that is, 70 million people who are not dying. That's extraordinary. And that is a frustration for those of us who work in this space, that there is a pulling back. I think we're very concerned that on current trend lines, the global fund replenishment target risks not being met. That we've seen multiple countries across Europe, debate going on here in the United States about what their role should be. People are saying we need to focus on domestic issues. There are other challenges. There are fiscal pressures. And our argument, which we're putting our money where our mouth is with that $912 million commitment, is these are very modest proportional commitments relative to total budgets, and you will get almost no investment that has a higher human impact. And that it's critical that, especially now with this pipeline of innovation we're talking about, that we double down, because if we don't crowd in these resources, if we don't build on these partnerships, and those are partnerships that are getting increasing co-financing from countries in Africa and Asia on the ground who know that the long-term pathway is to be self-reliant for those treatments, then we won't meet those targets that we're setting for 2045. The Gates Foundation's resources are significant. They are a fraction of what are needed to meet those goals. And so we're doing this as a very urgent call to action that by this November event, we hope and are cautiously optimistic that we will see the world respond again and make a very generous set of commitments.
Indeed, you describe it very well, very pertinently. The headwinds are very, very strong. They're all coming at us very, very powerfully. You talked about co-financing. I went to the World Health Assembly in May in Geneva, and then I've just come back from Lusaka for the World Health Organization Africa meeting. Rosemary, I'm not sure if you were there, but if you were, you would hear the term DRM, domestic resource mobilization. Yeah. And there are lots of countries, including the Nigerians, I think the Ivoirians, Cote d'Ivoire, the Zimbabweans, who have said, we read the writing on the wall, we were warned about this, we've been trying to step up. What are you seeing?
Yeah, so African countries are definitely determined to work towards stronger domestic leadership. There are plans and frameworks that the African Union members have been working towards. Of course, there are a number of challenges when you think about the fiscal space, when you think about the GDP and debt ratio and how that constrains government's ability to invest. But from an advocacy point of view, our biggest message has been to say that, yes, we need to continue to push. We need to continue to figure out health financing reforms that can actually unlock resources, the public resources, but also tap into partnerships, like unlock private sector money. But also the conversation around domestic resource mobilization, I think it's important to put it in context to say that while African governments are moving towards that direction and are talking about sovereignty, self-reliance and all that, it's important to couple that with global health solidarity, because even as we look at countries that are transitioning, transition is a process, is a pathway, and it has to be methodical and over time. And so I think partners that can come along with national governments along that pathway of transition and really I understand what milestones and what are the markers of transition and journey with countries in respectful relationships, equal relationships. I think that will help, because we are saying that, yes, we can work towards that leadership, but there can never be sovereignty without solidarity. So it's really important to talk about how partners can support national governments in making progress towards that pathway.
What do you make of the big push towards African health sovereignty. There was a summit in Accra in August, and of course, there's been a real buzz at this UNGA. How seriously do you think this should be taken? Because we've heard talk about sovereignty in the past, and it hasn't really gone very far. Is this different?
It should be different. It should be different. I mean, the thing is that the kind of shifts and politicization we've seen in global health right now, one thing is for sure is that the global health ecosystem was due for a conversation around how we reimagine and how we rethink global health architecture. And so I would like to think that we are at a point where we really need to think about that. We really need to think about how can we make the global health architecture better and work even for low and middle income countries? What are the challenges with the way the current architecture is shaped up, and how does it, in the way it's structured, limit that kind of progress? And so I think it's a good conversation and dialogue to have. What I celebrate is really the leadership to say, look, as Africa, we need to figure this out. We need to do something. But I think the point is that we cannot do it alone. I think it's not either all, domestic sovereignty and all that. I think it really speaks to the need for the global solidarity and even thinking about global health from a global security point of view.
And on that point of global solidarity, Mark, I mean, global health used to be a bipartisan issue here in this country and in many of the high-income countries around the world. Not so much these days. What do you think it's going to take in order to get us back to where we were, a consensus that this affects every country in the world issue?
Yes, well, first I want to emphasize that I think and truly believe that global health is not a partisan or even bipartisan issue. It is a non-partisan issue. It is an issue, it's a set of values that we all share, that are embedded in the Sustainable Development Goals, that was a commitment by every country in the world to their own citizens about a vision of a healthy and productive future for all their citizens. And I think even in the US, we still have strong support from both Republicans and Democrats in Congress for these global health priorities. We are engaging very actively with the administration about the US administration, about what can be done and the importance of continued US global health leadership. And it is important to stress the US has been by far the largest contributor to global health funding over the last 25 years, and to both the institutions like the Global Fund and more broadly in sectors like HIV. And so we are absolutely continuing to make that case. And while there are active debates, I think a lot of the proof will be in what happens at coming moments like the Global Fund replenishment. Do countries really step up? Do they put their money at where there are the most impactful interventions? And we will be using our voice, and we're cautiously optimistic that we will be able to do that. And just to match it, it does need to be matched by commitments by the low and middle income countries themselves. African countries have, for decades, made commitments that are embedded in the African Union about the percentage of their budgets they should be spending on global health, and the vast majority of African countries have not actually met those targets. And I think this is a moment where there is now very genuine debate and discussion at the heads of state level, at the finance ministry level, at institutions like the World Bank about what is that pathway, as it's maybe too self-reliant, but it's a pathway that has to be over many years, where it's matched by some of the global health support that institutions like ours and we hope high-income governments do continue to provide.
Okay, we've got just 45 seconds left. I'm going to pivot to you, Rosemary. Can you spend the next few seconds giving us grounds for optimism? What makes you feel optimistic about the future? You've been working so hard for so many years in this space.
Yeah, and what gives me optimism is that going back like 30 years back and where we are now, this journey has been characterized by global solidarity, what we are talking about, with the rise of institutions like the Global Fund, partnerships like PEPFAR, the philanthropy sector coming on board and having science rise and rise. And so I think just looking at how far we have come and the fact that we are close, we have the tools. If we could get the tools, scale them, and ensure that we can roll them out in low and middle income countries and make sure that to the last village, these tools reach and actually transform lives. So translating science into equitable public health impact. I'm optimistic about that if we can double down on the finances and we can think about strategic delivery models.
Rosemary Mburu, Executive Director of Owaki Health, and Mark Sussman, Chief Executive of the Gates Foundation. Thank you very much indeed for being my guests on this first edition of The Threshold.
And now, please welcome the World Health Organization Director General, Dr. Tedros Adhanom Ghebreyesus, the 68th U.S. Secretary of State, John Kerry, and Seed Global Health CEO and WHO Special Envoy for Climate Change and Health, Dr. Vanessa Carey, for a conversation with FP's Editor-in-Chief, Ravi Agarwal.
Hi, everyone. Thank you for being here. I think we can do a better round of applause for this group on stage. It's a real honor and pleasure to have the three of you on stage, Secretary Kerry, Dr. Tedros. I've interviewed each of you separately, but never together. Secretary Kerry, let me just start with you. These two are here for very obvious reasons, you less so. We're here to talk. We're here to talk about health.
I've never had my place in life put as succinctly.
But this is important because, you know, this is UNGA week. You know, hardcore geopolitics is the order of, you know, the day of business over there, which is, you know, most of your old career. But you're here today at a health forum. Just tell us why and connect the dots for us there.
Thank you, Ravi, and thank you for the privilege of being here. And I'm honored to be here with Dr. Tedros and my daughter. Let me make it clear to everybody. I had to wrangle to get myself in here. I wanted to come and be part of this, and I appreciate my co-panelists in permitting it for the precise reason of the question you just asked. What the hell does health have to do with this? And the answer is everything. Greenhouse gases are pollutants. We used to talk about pollution. We don't now for some odd reason. 7 million people a year die from the bad quality of air. And that's getting worse in many parts of the world because of coal-fired power and so forth. There's a direct linkage to what's creating the challenge of climate and how you can build community and build adaptation and build resilience to those things. And a community that is ravaged by a disease or doesn't have adequate health care, doesn't have the ability to be able to take care of people, so the community is going to fall apart. And then you have refugees, augmented by the fact that you have stress, you know, heat stress levels that people can't work in, people can't live in. So it's absolutely imperative that we all connect the dots. And I'm privileged to be able to hear with Dr. Tedros and my daughter to do that. Vanessa can give you much more of the particulars of what it's like building this on the ground. But you compare a vision for the planet, which we need, and the challenge of climate, which is really the biggest physical challenge to all of us at this moment in time. And it's 100% certain. It's not 5%, 10%, 20%. It's 100% certain that the impacts that have already been coming true, already the predictions of the best scientists are coming true, and they say it's going to get worse. And that's going to shred the ability of communities to have the safety and the capacity to grow, take care of your kids rather than being in the hospital or taking care of one person. Or if there is no hospital, what happens then? The community begins to just shred. So there's a direct linkage here, folks, and it would be wonderful to have had a presentation yesterday which didn't push people away and give people reason to wonder why they shouldn't challenge the current world order, instead of and be able to build out a global response that gets the job done. Health is a critical component of winning that battle, and in two terms. One, in terms of convincing people that there's a reason to be engaged and do other things, and two, getting the job done and therefore not having the health crisis that could come otherwise.
Well said. Dr. Kerry, the last time you were on the stage and you wrote a piece about this in Foreign Policy, telling the world how health policy is foreign policy, and that's what I'm hearing here as well. When you see the level of polarization and divisiveness that we have seen at the UN this week already, and given the work you do in the health sector, what is your sense at a ground level? How do we convince people and policymakers that this is an area that needs more care, more attention, more investment?
I mean, we did. We talked about this last year, and we talked about health being framed as defense. And I think the reality is that there is a deep mismatch happening right now in how we're prioritizing billions in defense versus trillions in defense versus 18 billion that we might be spending on health in this moment or need to spend on health. You know, we talked briefly about the polarizing rhetoric that we see today. I don't think it's actually helpful for us to focus on that, really, because whether you call it climate change or you call it the greatest con job, climate change is here. We're living it every day in the hotter summers we see, in the hurricanes that are slamming at more frequency and more ferocity that are affecting our societies, taking away our homes, changing disease patterns. And I'm a physician. And so whether it is delivering direct care to people who have asthma attacks and then they can't go to work, or if it is building health systems and health system resilience to meet the rising burdens of climate change, you know, we're seeing health be a very profound and lived effect. But to mobilize this moment, I think we have to focus on solutions, cutting greenhouse gas emissions that are actually making us sicker, and supporting communities to be able to adapt and have the things they need to be safe, prosperous, and have opportunity. And one of the key links that I think has to be made, and we've talked a lot about this, is that health actually is also wealth. When you look at the decisions getting made in the world today, it's economic. We are making economic decisions. Private sector, 1.8 trillion of assets now, the highest ever in history. And at the same time, that makes sense, that's their mandate, but how are we building that into sustainability? If they're smart, they're investing in the health and well-being of their workforce. Because it turns out extreme heat is costing the United States $100 billion a year in productivity currently. We know that just small adjustments can transform actually that loss into profit and sustainability going forward. And I think understanding that connection is critically important.
Dr. Tedros, you must be listening to all of this and feeling like we're all preaching to the choir. The WHO is also quite polarized right now. You have, you know, the United States doing what it's doing with your organization. What is your sense of a way forward? I mean, how do you bring countries together to focus on the message Dr. Kerry just said?
Thank you. Thank you, by the way, for bringing us all together. With John, we were foreign minister same time, and best allies. We used to work together very closely. And of course, later on, as you know, championing climate change and health. So I had the opportunity again to stay in touch with him. And of course, she's the bridge. Vanessa is the bridge. And she is our special envoy. So I think you have a good reason to bring us, the three of us, together. Yeah. I fully agree with Vanessa, by the way. We have to focus on the solution. And WHO is passing through a very turbulent, what do you call it, times, difficult times. It's affecting us significantly, but we're trying to see the challenge as opportunity, turn it into opportunity. And it's helping us to look inside. And we're trying to make the organization more focused on its core mandate, sharper, and more independent. Actually, we saw this crisis coming. In 2017-18, the major risk we identified for WHO was dependency on few traditional donors. which may have two serious consequences. One, shocks like now, which causes the crisis, a shock because of funding cuts. And then the second is when some countries come with big money, there could be that it may compromise in our independence. So the solution we propose then is broader donor base. And one of which the measures was for all member states to share the burden and to increase their membership fee, which they did, by the way. They agreed in 2022 to increase by 50%. This is the highest in the history of the organization. The largest increase was 3% in 77 years. So this was a significant increase, 50%. So they have done already 2 installments, by the way, but this has nothing to do with the US. And the way forward is the same, for all countries to share the burden. Then we can prevent similar shocks from happening, but it can ensure WHO's independence as well. So the solution now is to move in the same direction. We're doing that, by the way, for WHO, and we see actually more opportunity. But as you said, the most impacted actually are the countries. And we're not worried about WHO, we're worried more about the countries that have been, in fact, impacted by the significant aid cuts. And we're trying to work with them. And even the solution for them is, for those countries, they have to see it as opportunity. And it should start from inside. For instance, many countries are affected by this mindset of aid dependency. And cleaning is always inside out, right? It should start from inside. So our proposal is, especially I'm from Africa, and it just embarrassed me actually to have that mindset. We have to clean from inside and try to really move into self-reliance. There are opportunities in our countries, in the developing world at large, to finance health from domestic resources. And we're advising countries to do that. But I'm very much encouraged because many leaders I have spoken to, even during the past week and the last 7 months, I can see a change in mindset and moving into self-reliance and saying we can have immediate solutions like taxes on alcohol, tobacco that can generate some money to cover the gaps, which many countries are doing. And for the long term, it could be the public health insurance, a strategic solution. Wow. So self-reliance, I think, will be the case. But they have to look inside and understand there is an internal problem. And of course, there is the external as well. But they have to give priority to the internal, address that. And then they can work with all donors to address the external problems as well. So the future is see this as opportunity and try to ensure self-reliance.
Dr. Kerry, yeah. If I can have you pick up there, because I think this is a very powerful and hopeful message. What is your sense of, we were talking about the USAID cuts earlier, how are you seeing countries around the world pick up on this and turn the current moment into opportunities on health?
I think Dr. Tedros is right. I mean, country-led plans that are really contextual to the problems, prioritizing the needs and opportunities of the community is going to be the way forward. But we need to be clear. The abrupt cuts that we have seen are killing people. And it is not making anyone safer or more prosperous. It was just reported, for example, it's going to cost the U.S. taxpayer $6 billion to close USAID. That cost is egregious. But that could be saving lives, right? It's been estimated that almost 500,000 people have died directly since the cuts have happened. So we can sit here in New York and have our conversations, which are important, yes, and we need to convene and we need to focus on solutions. But make no mistake, people are dying today because of what is happening. And so there does need to be a bridge. There does need to be a mobilization of that 1.8 billion, trillion profit. We need to be moving that forward into solutions that are thinking about our joint prosperity and well-being. but that are fundamentally saving lives. And it is not incongruent to want to do the right thing and to invest in health and well-being, to close equity gaps, to make people safer and healthier, and still see economic growth, or have your household have income, or actually do good and do well. These are very feasible pathways, and there are solutions out there, and it's going to require all of us to lean into those solutions, be smart, be pragmatic, and then to bring that forward to policymakers, but to step away from some of this politics. We do need to invest in country-led plans. Dr. Tedros and I are working together on a couple initiatives, along with many other partners, but that are being led by countries to mobilize domestic financing, to look at how those individual contributions can be. But again, if the global architecture doesn't shift, it can't change. Africa spends more servicing debt than it does on health and education. That is a problem. So we have some fundamental things that we have to correct, but we do, again, need to think about how we can find the viable path forward, the shared language and the understanding that all the goals that we may want, whatever our political or partisan rhetoric is telling us, is actually quite aligned. And we just need, and I think that there are very pragmatic paths we can put forward, but it is grounded very much in the reality that we are talking about human lives every day, whether it is tons of carbon or whether it is aid cuts. This is whether people live or die.
Secretary Kerry, I feel like more than anyone else, you have done work in the area of trying to find common ground between adversaries. And I'm thinking now about, at the height of US-China competition, you were trying to find a pathway to speak to your counterpart at the time, Xie Jinping, the climate envoy, to find commonality. How can we work together on an issue that matters to the world, just as health does, climate does? Is there any lesson there? Because it often feels like, given the choice between competing with China or constraining China and working together on health or climate, our policymakers here often choose constraining. How do you change that paradigm?
By doing what you have to do. By proving to people that it makes a difference. When I was climate envoy for President Biden, Washington was in full-throated force, competing with itself to see who could be the toughest rhetorically on China and sort of pushing China away. I found, working with China, China was a critical partner when we stopped Ebola in West Africa. China was a critical component of our being able to get the Iran nuclear agreement done, and to be able, in addition, to get all the chemical weapons out of Syria during a conflict. First time ever that weapons of mass destruction have been taken out during a conflict. How did we do it? Not just because we did it. I mean, we pushed it and we organized it, but others joined in that effort, including China, Russia, and others. Now, does that mean we don't have conflict with them that we have to address? Of course not. We have countless challenges with China, theft of intellectual property, Taiwan, Uyghurs. I mean, you run the list. We have challenges, but you've got to sit down, and that's what diplomacy is about. So even in the midst of all the challenges we faced, President Biden allowed me, deputized me, to continue to talk with the Chinese. And guess what? Even then, President Xi allowed President Xi Jinping and others, we made a difference. We got China to agree to list all greenhouse gases. Methane wasn't included. They now list all greenhouse gases in their NDC. We got China to agree that they would cooperate on a special methane reduction plan, because methane is 100 times more destructive than CO2. This is science, by the way. Science, mathematics, physics, and science. And you got the point. So it's also so basic, it's beyond belief. I mean, if we divided the end of this room into two rooms, and you had a wall over there, and we said, all of you, you got a choice. One room has all the coal-burning fumes and everything, particulates are coming out in that room. The other room has pure oxygen. Which room are you going to walk into? 100% are going to walk into the room with pure oxygen. That's the choice we face with respect to the climate crisis. What is our problem? Our problem is we are burning fossil fuel without capturing the emissions. If you capture the emissions, you have a whole different debate. But we haven't proven we can catch those emissions and build it out at scale and affordability. We can build out renewable energy at scale and with confidence. So these choices are just so fundamental. And I came to the conclusion, thanks to my daughter, that we have to change the narrative. We have to get people to understand what is really at stake here. The ability to work, the ability to live, the ability to build community, the ability to be healthier, the ability not to crowd our own hospitals at home with the detritus of what we burn without capturing those emissions. So we're voluntarily continuing, some of it not actively choosing to, but not making the choices that would prevent it. And we're not doing that. So it's acts of omission and acts of commission that come together to create this crisis. And we just, what do they say when you're digging a hole and getting deeper and deeper in the hole, the first thing you got to do is stop digging. Mm-hmm. And that's what we have to do. And the benefits will just be extraordinary in our ability to be able to address real issues globally. You're not the leader of the free world just because you beat your chest and say we're so exceptional. We're exceptional because we do exceptional things. Dealing with AIDS in Africa, what Bill Gates did was exceptional. What America did, helping to get a generation of children who are not born with AIDS, which makes a huge difference to all the other choices you face in building community and life. So, I think that we just have to hold our ground and continue to fight. I am actually very optimistic. I'm involved in trying to accelerate the energy transition, and I see all kinds of technologies that are ready to come online. We can win this battle, folks, but we got to get the deniers and the disinformation artists out of the way and use the full power of our country and of our brains to get the job done.
Welcome to our dinner table.
I love it. Can I be invited?
Yeah, we allow time. We at least get to eat.
Yeah, we are way out of time. Dr. Tedros, I'm just going to give you maybe 30 seconds. Bring us back to health. When you listen to a message like that and the power of diplomacy done in the right way, what hope are you drawing from the moment right now? And are there any green shoots you're seeing that could bring a message like that to your domain?
Hope. I think, this year, for instance, I can give you one example. There was negotiation on pandemic agreement for the last 3.5 years. And it was approved last May. Many were skeptical. But it was approved. Meaning, it shows you that multilateralism is alive and well, despite the noise. So that gives me hope. And I can give you a long list, actually, what happened this year. But I think that is that's very important and enough, because this is an international treaty that all member states have agreed to move on.
I love that. Thank you for giving me hope. Thank you for giving everyone hope. Secretary Kerry, Dr. Tedros.
Please welcome the Rockefeller Foundation Senior Vice President of the Health Initiative, Dr. Naveen Rao, for a conversation with FP's Andrew Solinger.
Well, that's a pretty easy act to follow, I would say, Dr. Rao, don't you think?
Absolutely.
Small order.
Absolutely.
The bar is just medium. I wouldn't say it's super high. But really, what an energetic, scary / hopeful way to think about where we are today and the challenges that we face and where our leadership is. And I'm super grateful for Dr. Rao to be joining us here from Rockefeller Foundation. And I'm also incredibly grateful that we're hearing from some of the large, focused, meaningful donor organizations who can really talk a little bit about how they see the world changing and their role in that world. And that's really where I'd like to open up the conversation with you. And that is about how do we change the structure that we're in right now to make a difference with all of those issues that we just heard from Dr. Tedros, from the Secretary, from Dr. Kerry.
So
It's a
Andrew,
lot.
thank you. Thank you. As you said, it is a hard act to follow, but on the other hand, they have warmed the stage, and it's easy for me to build on what they've said. So I don't have to say all the stuff they said. I'm just going to build on top of that. Truly appreciate it. So, you know, health is what holds it all together. As a practicing physician, I remember seeing patients and families come in, and then because of a catastrophic health event, going into poverty. The story in India would be every year about 10 to 15 people come out of poverty, and the same amount go into poverty. And the ones who go into poverty most often, it's a catastrophic health event. Father has had a heart attack, and the family has to sell that little piece of land or the cow, and the next thing you know, God forbid, the father has died and the cow is gone and it's destitution. So health is what holds it together, and actually Director General Tedros says it the best. He's quoted as saying, when you have health, you want many things, but when you don't have health, there's only one thing you want. And that's everyone shaking their head. That's universal. It doesn't matter which religion, which culture, how you look.
So true.
Right. So let me end this health story with what we as children are taught in India. Is they start with saying, if you have good health, give yourself 1, and then add zeros, all the good things that have happened, and see how rich you are. So it starts with, if you've had a good, safe childhood, you're 10. If you have good education, you're 100. If you have a good marriage, you're 1,000. You have a good job, you're 10,000. It goes on and on and on. You've made millions of dollars, and you become a billionaire, and you really are doing very well. And suddenly you don't have health. And so if you take that 1 away, that billion becomes 0. They're all zeros without that health. So I've made a sufficient case that health is important. I also want to build on what father and daughter Kerry talked about. And that is, if we were to build a resilient health system fit for purpose, we have to move from the health systems that were built post-World War II, that made sense and that worked for that era. But today, the donor-driven top-down approach to global health is no longer valid. It is now the country-led demand and country-led need and country-led strategies and focus that we need to support. It has to be a pull model based on what countries need and want, not a push model based on what donors want. So health is important. We need to restructure global health, and the way to do it is a bottom-up approach.
Outstanding. So Rockefeller has been of paramount importance to the global health system for a very long time, a huge focus of the organization. And you've seen lots of change and challenges, hearkening back very recently to the pandemic, but many different afflictions and crises before that, both financial as well as medical. And now we're in a polycrisis. How are you approaching this moment, this change differently, these reforms differently than you have in past?
First, we're acknowledging, we're acknowledging that health is the human face for climate change. Somebody told me the other day that if you go on Google and search the word climate change, if you search the word climate change, you're going to see images, almost 3-4 screens, almost 20, 25 images before you see a human face. You'll see polar bears, you'll see smokestacks, you'll see a lot of images on climate change, but it takes quite a long before you see a human face. And we're trying to say that needs to flip. Health is the human face. In fact, if we were to talk about the effect of climate change on health, that is the existential crisis. That is the lived experience. And I have a feeling personally that is the way we need to approach it, not 2.3 degrees or get into the rhetoric of mitigation, adaptation. All we need to tell you is you, your children, your parents are all being affected by climate change here and today. And if that is the case, what we're trying to do at Rockefeller is see how can we re-architect and redesign the global health architecture, but focus it on climate change. And that is the big difference. And we have an area of focus which cross-cuts everything. And if we start with early warning systems, so basically we need a smoke alarm and a fire engine. A smoke alarm without a fire engine is useless, and a fire engine without a smoke alarm is useless. So let's start with the smoke alarm. It's basically early warning systems. How can we get the meteorological organizations to work with health organizations? Airline industry, 100% use meteorological information. The plane won't take off or land without knowing the climate.
That's right.
But only 30% of health department use meteorological information when they're making plans. And that needs to change. But for that to change, the meteorological people also need to give us information that the health team can understand. I saw a plot graph with scattered dots, and the meteorological person was all excited, and I didn't know what it was saying. Basically, it was rain. It was going to rain. And that needs to, so we need to be able to get the two together, a really strong early warning system. But that is not enough. We need the fire engine, we need plans. So we need drills, we need work plans. We need all of society. So, for example, if a heat wave is coming, in the middle of the heat wave is not to ask the question, should we close schools or not? Should we have cooling stations or not? So just like in a building like here and most buildings, you have fire drills. And the fire drill is done when there's no fire. And everyone knows where to go, what to do, who's responsible. We're saying, let's get these work plans and drills in place for the heat wave that is going to come. So when we are told in a week from today we're going to have a heat wave, 50 degrees for a week, let's have the plans.
We're being proactive, not reactive. You're such a good guest because our next speaker is from the World Meteorological Organization, so we're going to be able to talk about that. I really appreciate that setup.
I know that. They're all friends. And actually, I'm setting it up, I'm paying it forward.
Very good. Last question for you, because we're almost out of time, and we do want to work on that segue. I don't want to take us away from that. There have been a lot of promises and a lot of talk. And often, when we try and, we were talking about hope earlier, and we try and take advantage of crises by not wasting a good crisis and talk about how we can change structure. So a lot of promises get made. How do we ensure this time around that there's action following on those promises for health, governance, and structure reform?
Yeah, we need an all-of-society approach. So health of a community can't be the responsibility of the Ministry of Health. So if you have poor education, you're going to have poor health. If you have poor housing, you're going to have poor health. If you have no job, you're going to have poor health. If you have poor nutrition, you're going to have poor health. So to maintain the health of community, you need all of society approach. And unless we do that, and I feel this time around, that is the idea of getting all of society to protect health. And then also global cooperation and how do we all come together to help the countries. There is enough data coming out now. People want to be able to have their countries collaborate when it comes to health. On health, it's very high. And so health is the tip of the spear that we can then get global cooperation. It is the tip of the spear that can get all of society. And if this works, we can do it for education, we can do it for food. This whole concept that it's all of society. So
the other zeros?
It's the other zeros.
Or the zeros, not the one.
That's right. So I really feel that is the way out of this. And I also see the glasses half full. I'm just quoting what Tedros just said. He feels confident that this time around, there's a mindset change. Countries want to step up. They want to get themselves off aid. They want to transition. And I believe our duty is to be there for them.
Ground up. Fantastic. Dr. Naveen Rao, thank you so much for the discussion and for the work you do at Rockefeller.
Next, please welcome to the stage Liverpool School of Tropical Medicine Chancellor, El Haj Assi. Welcome CEO Jan Arne Rottingen and World Meteorological Organization Secretary General, Professor Celeste Saulo. for a conversation with FP's Andrew Solinger.
Well, Celeste, that's quite a setup you got there from Dr. Rao. Very, very impressive. So this is a great discussion to follow on everything that we just heard. We're going to get into some nuts and bolts here. I think the stage has been set appropriately, not just for three chairs that matter, but three of the right people. So topics we're going to discuss. What does a more equitable and resilient global health architecture look like in reality? And how we're approaching global health reforms differently this time around. We're going to talk a little bit more about the overlapping crises of climate change, conflict, and inequality. Health doesn't just live in hospitals and in clinics. It's shaped by agriculture, education, infrastructure, our living world. And I think the folks that we have here are going to be able to talk about this cross-sector approach. Jan Arne Rodigan of the Wellcome Trust has been at the forefront of using philanthropic capital to tackle global changes. Professor Celeste Saulo of the World Meteorological Organization can talk a little bit more about the predictive power that we can bring to bear. Weather can actually save lives, not just ruin your weekend plans, and we want to really think through that. And Elhaj Assi, did I pronounce that correctly? Great. Chair of the board of the Liverpool School of Tropical Medicine, who has spent decades putting equity and community resilience at the center of global health, and of course served with the Red Cross and can give us a little bit of a sense of what he's seen on the ground. So Jan Arne, I wanted to turn to you first. The global health system was basically set up 80 years ago. Does it need to change?
Yeah, I think it needs to change. And yes, it was set up 80 years ago, but we probably did a big change also approximately 30 years ago, because the post-world sort of institutions, the UN system and the international financial institutions were set up after the World War. And then we also saw that these institutions do not sufficiently deliver, and in particular when it comes to health outcomes. And we also knew that there are so many new innovations. It was in the early days of actually seeing the ability to handle the AIDS crisis. And we saw that new innovations, new technology can be really scaled up and really reduce these risks around the world. We were probably too eager to get results too quickly in some way. I should not say that that is not good, because the Global Fund has saved 70 million lives through its investments in TB, HIV, and malaria. And so it's tremendous results, but we haven't been able to really establish the long-term sustainable solutions, which is about bottom-up health systems rooted in communities, rooted in a primary healthcare approach, and rooted in understanding that any government would need to have responsibility for the health of their people. And climate is such a big challenge for all of us. It is a multi-sectorial challenge, and we also know that health is, as you mentioned, is determined by so many other sectors. And the only sort of people, because this in the end is about people and leaders, who can see that totality are governments and leaders in countries who are elected on behalf of their populations. So we need a shift, in a way, a bottom-up approach, a health sovereignty approach, which comes with responsibilities. And then we need to understand what are the functions that the global system need to provide. What are the global public goods, so-called, that can make sure that we handle the global threats like climate, like pandemics, like epidemics, and make sure that research and innovation can reach those with the biggest needs. Instead of now we sort of set the dictates with very good intentions from New York, from Washington, from Brussels, from Geneva, from London, where I am. And I think we just need to switch that.
Great. Quick follow-up on that before we move on. What role do you see philanthropy playing in that, alongside multilateral institutions and countries themselves? The instinct, we had a lot of big announcements the past couple of days, which are fantastic and wonderful, but that can also be a bit top-down. How do you see that working without being heavy-handed or duplicative?
Yeah. So I joined Wellcome 1.5 years ago, January 2024. I came to one of the biggest foundations in the world. We have an endowment of $50 billion, and we can do a lot of good in the world by supporting science. We have good governors, us is one of them. But what I really, actually, when we saw the aid cuts that US made very quickly, and other countries are announcing that gradually will happen, we understand that philanthropy can never fill those big gaps. So that speaks to the role of philanthropy. It speaks to the role of foundations. We can be catalytic. We can initiate things. We can try to bring partners, both from public and private sector, together. But we can never be the sustainable funders. That would either be governments, either national governments for their people, or through a collective action. And I hope we can play catalytic roles. And what we're now trying to do, given that we do not fund implementation of health aid, but we fund supporting science and innovation, we are also trying to facilitate discussions and dialogues across 5 regions of the world. What are the needs of countries? What are the needs of communities when it comes to the global health system? And how can we, in a way, initiate a bottom-up approach to calling out the changes that we need to see? And that is a role no government can play,
right,
because they are not independent. We are so lucky to be completely independent. We only are accountable to our board. With that comes a lot of responsibility, and the only people we are responsible to is society, and we need to be accountable then to people around the world, and this is the way we try to do it.
We, of course, had Dr. Tedros here a moment ago. He's also, in a sense, accountable to those countries as well. I can take that
But he's
more
accountable
global view.
to governments,
Yes,
which is different from being accountable to people. I think we also need to respect that difference.
Agreed.
Yeah.
I want to come back to the catalytic investments
Sure.
and how to make them more long-term than short-term. But Celeste, if I may, Dr. Solo,
yes, please.
Such a great tee-up from Dr. Reao. So I'd like to ask, climate change is essentially a health crisis. We've all agreed that. What are the tools and innovations from meteorology, forecasting, early warning, data sharing? What are the ones that can most immediately improve how health systems can prepare for pending shocks? And what role will AI play? We had a tech and AI forum here yesterday. We talked about AI all day long. It hasn't really been brought into the conversation yet today. Maybe you could touch on that as well.
Okay, well, these are fantastic times. And yes, please stand with me with that. Because we have a lot of opportunities that are completely untapped. And I think that you already mentioned the role of philanthropists as catalytic. Yeah. But you asked me about the forecast and the innovation and everything. So let's start from the very beginning. There is a global public good we all need to protect. That is data. Data that is gathered by metadatabases, that is the basis for the weather app you use to make everyday decision. And of course, when that translates to health, it has a huge impact. But what is the meteorological community thinking now about? Is it about this technical kind of approach, or is it about translating what we do? And I think it's about translation. That is our next challenge, really, because there is a sentence we use commonly, is it's not about what the weather will look like. That is like the meteorological perspective. It's what the weather will create to you. What will happen to you with the weather I'm forecasting. So this is a completely shift. It's a huge shift because it's not the same what will happen to a person that is in hospital, that what will happen to a person that is working in the field, or this a person that is working or driving a car. It's not the same. So for us, translating that is really the next challenge. And AI can help us a lot because it's about building these new communities of practice where we provide the meteorological information, climate information, but we need to translate that climate information into climate intelligence or decision making. Mm-hmm. And that is a new kind of paradigm. And that is where we have great partnerships where you, like Wellcome Trust and Rockefeller Foundation, are helping us to really do these first steps into translating. And so, yes, AI brings a lot to the forecasting challenges we have. Yes, of course, we were one of the first users of AI 20 years ago. But that would not translate into real actionable decision making. So now the challenge is there.
Could you enlighten us a little bit on specifically what Wellcome and Rockefeller are helping you to explore? An example would be wonderful.
Well, concretely now, we have started what we call the Global Heat Health Information Network. It's a place where we gather people from health, from weather, from the academia, to understand how we can better translate the meteorological information into health information. And this is supported in a way that we started a hub only in Singapore when we had the possibility to do that. And thanks to the support of philanthropists, we now are creating new hubs for South Asia and for Latin America and the Caribbean. So it's about these pilot projects that can be scaled up to showcase to governments, which are the ultimate responsibles to translate this, and showcase that this is helpful, this can be changed, this can be actionable information. And let me just provide you an example. For health, it's not the same to have a maximum temperature of 32, 35, or 40. Has nothing to do. For a meteorologist, it's just a number. For a health practitioner, it's a decision making. Should I prepare my hospital differently? Should I move people? Should I keep the kids without going to school because they are at risk? So for a meteorologist, it's a number. So we need to work along those lines together.
That's
yes.
great. I love it, Celeste. And I would love to come back to you on that global cooperation a little bit more, because that's a key part that we're missing. But Az, I would love to bring you into the conversation and what is really interesting. I mean, you're so knowledgeable about so many things, but you were head of the International Federation of the Red Cross, as I mentioned. And you could tell us a little bit about what you've seen on the ground and what these impacts are, what communities are encountering, how they're adapting or not adapting. And examples are great. It's just so tangible and helps us understand and encapsulates. Maybe you could share what you've seen and heard.
We've seen that shocks and hazards are more frequent, more severe. We've seen that the shocks and hazards are natural, the disasters are human. Why? We know that every year there will be a monsoon season. It will happen.
Predictable.
We know that every year the Zambezi River will get out of its bed and it will flood parts of Mozambique and Malawi and end out to Zambia. If we have that, do we necessarily have to have a cholera outbreak every year? If we have a monsoon season, do we always, have a water sanitation and hygiene issues, where latrines, will be infected, and another cholera outbreak, year in, year out? So the question is, if we are so smart, to predict, that the natural shocks will happen, why aren't we not smart enough to make sure that it will not turn into a disaster? And that's where the human factor comes in. So nowadays we all talk about, forecast and forecast-based, financing, prepositioning of supply, when you work in humanitarian setting. We talk about early warning, early alert. But the question is the early warning, early alert goes, with an early action. And when we have an early action, how long will we be accompanying those communities that are affected? And then when we leave, what are we leaving behind so that next time around, when they're facing the same shock and hazard, they will not find themselves in the same, level of vulnerability. I think this is the challenge, that we face. So year in and year out, we panic, we go in, we think it subsides, we disappear until next time around. So that cycle of panic and neglect within which we find ourselves, that we need, to get out of. Because of also the frequency and the protracted nature, of those challenges, what we also see is that the lines, that we used to see very clearly between emergency situations, kind of a transition phase, to development, and then later on resilience, those lines are getting blurrer and blurrer and blurrer. So what it calls for now is, hit and run will not make it anymore. So we need, to engage in a kind of a continuum, of early response, resilience building, drawing those lessons, and then making sure that also preparedness is not just, a word, but it is translating into very concrete action and measures, that can be taken, to allow communities to withstand, those shocks. What we also learn is that, sometimes we human, we forget that we are not, the only species on this planet. So we share this planet with, other species, but our individual behaviors, our modes of consumption, our modes of habitat, our demographic pressure, all of that come together, and then we're encroaching more and more and more into the natural habitat of other species. And that cohabitation, of course, is deadly. Those species, can live, with many, of the challenges and vaccine and health issues, but we die, from them. Now, what do we need to do, in sharing, that ecosystem, together with other species through our action, our, again, consumption rules, our behaviors and attitude, is something also that we need, to reflect on. Just one concrete example, of that. So, working in the disaster scenes, over many years, when I was heading the International Federation of Red Cross, we believe that we know what we need to have in place, in order to respond. But every time when there is a shock, we learn something new. So if you have, your package of interventions, there are so many things, that you put in there: water, sanitation, hygiene, purification tablets, some trauma, then you can expect, and so on. And then you come into Mozambique, when there is a flood, where people are running out of their house and going up to the roof or up to the trees, snakes are also running out of the water and then going up to the trees. And then there you meet, where the antivenom. It has never been there. So tomorrow we'll have a big event, to strike out, anti-snake bite, and then to put, antivenoms that is becoming, one of the key elements, of intervention, just to give an element of illustration to it.
That's a really great example and something you wouldn't normally think about. And so as we build this knowledge, we have to learn and apply it going forward, and not treat and manage the same crisis twice and the same issues twice and get caught short again. Yanarna, we were talking about catalytic change and investments. Wellcome has been on the front line of responding, not to crisis moments necessarily, just weather-related crisis moments, but the big trends, the pandemic, and some of the big diseases that we've seen come out. How can we make that catalytic investment longer term and less short term, and think about that in the broader scheme of trying to change the structure of global health governance? So
maybe two things. One, we are just one foundation, just one philanthropy. So we believe that partnership also with other foundations and philanthropy is so key. Specifically on climate and health, we've established, together with the Rockefeller Foundation, a climate and health funders coalition. And because we, of course, foundations, philanthropy come in with different objectives and different mandates. It means that we cannot cover everything. I said very clearly we are supporting science. Sort of that's our constitutional mandate when we were set up 90 years ago. Others can be much closer to implementation, supporting things on the ground, and scaling up and financing that. We all have different expertise, so how can we also work better together so that not each individual foundation need to do the full assessment of what they can do vet individual projects and then really decide individually. So how can we get sort of an economy of scale almost when it comes to philanthropy? But again, back to what I said, we are only catalytic, even when grouped as a coalition of funders. So that coalition is now focusing on heat, on air pollution, and also on data. So the climate services that Celeste talking about, and the need for longitudinal data and to translate those data into health action. But then more broadly, we heard, I think, both from Naveen now and from the panel with Tedros and Vanessa and John, that the global health system needs to change. And again, that change needs to come from the countries and needs to come bottom up. It's great to see leadership. Yesterday it was the Accra reset leadership from President Mahama from Ghana. We've seen other leaders, in particular in Africa, calling out clearly that they will need to take the destiny in their own hands. But we see sort of this as a trend now to sovereignty, which can be framed positively, and I've framed it very positively in the sense of responsibilities and needing to build it up. But it can also be framed partly negatively, because sovereignty can also be about, first and foremost, only thinking about your own population and your own country. We can say country X first and so forth. So how do we sort of blend the positive drive of sovereignty and responsibilities still with collective action and the need to work on things together? We need to still scale up innovations for global health. Gates Foundation and Wellcome, we are now investing in a large clinical trial for the first, hopefully, new TB vaccine in 100 years. If it's successful, sufficiently successful, it will be on the market maybe in the 29 or 2030. But to make that happen, it needs to be scaled up and financed.
Yeah.
And that demand needs to come from countries. And how can the global health actors come together, already now start planning? We actually started doing that to the TB vaccination accelerator and the council. But it needs to be, I think we need to be much more focused on where we need external finance and in which context do we need to substitute, or even on the delivery end, because the systems are too fragile. And where do we just need to build up and support the government's efforts in establishing universal health coverage and primary health care. We need to be much more differentiated. Today, we are the aid system in some way in too many countries. We need to be more focused and then really build on partnerships and more coherent financing.
It's great to hear how you're collaborating amongst your philanthropic partners and trying to affect that change and lever your resources in that way to bring it to reality, which is wonderful. And Celeste, I would love to come back to you. We talked a little bit about what we see in the meteorological world from cross-border collaboration. I'm wondering if there's any lessons that you think could be applied from that world into the world of health as we share data from weather and forecasting across these two different sectors and try and combine to make results. How do we get these different entities to work together, these governments?
Well, I think that the World Meteorological Organization and the meteorological community has a very nice history of 150 years sharing data all over the world. So at the same time now, if you look at your watch 12, 193 countries at the same time are getting observations that they are sharing now together. And in a 10 minutes window, that will be available for all the world to prepare the forecast, the next forecast cycle. That is happening now while we are here. So it is possible, yes, it is possible to share the knowledge, the data. It's about really making this collaboration something that goes not only transboundary, but I would say transdisciplinary. I think in health and in other areas, it's more complex to share that data. Sometimes there are some, I would say, confidential matters that should be taken care of. But in the end, what the WMO can say is that whenever you share data, you are one step ahead to manage your risks to gather more knowledge, and then to be better prepared for what is coming. So it's about using this experience, and it's only for the good. And again, I will go back to the idea that this is a responsibility of the countries. And WMO can collect that, but it's a responsibility, a fundamental responsibility of the countries, and to sustain this network is a fundamental responsibility of the countries. But in terms of health, I would say, and how it impacts people, joining the efforts of the Med Services with the health ministries is such a rewarding experience. Because when you see that you are actually more capable of saving lives, thanks to having a previous collaboration where you could translate your information into something that was relevant for the health sector, that changes your life as a community. So for us, our partnership also, not only at the level of partnerships with the philanthropy, but with World Health Organization, with Tedros, team, having this collective understanding on how we can support ministries of health and ministries of environment and med services together. That makes a big difference.
Jan Arne, I'm going to come back to you in 1 second. I know you want to comment on that, but just a prompt for Az to think about. When we talk about data and we talk about this information, we're in a crisis of trust right now. There's, and we're not even going to get into the U.S. and what's going on here, but people are not sure what to believe. And I'm just curious if Oz, you can think about this for a second, and then we'll hear from Jan Arne. How do we make sure these communities that we're working with trust the data that we're going to be giving them and believe what they're hearing? That would be one thing to think about. I would love your views on that. But Jan Arne.
Yes, trust in data, trust in science is a platform. I won't go there. But just to illustrate because the best ideal situation for everyone is sharing, but it's a game theory problem, because if we start become transactional, the second best outcome will be the outcome, and that is not to share. And in health now, we have real live discussions on this, because it's not about weather data, it is about biological, genetic data, it's about biological samples. Currently, there is an ongoing discussion, as many of you know, the pathogen access and benefit sharing arrangement, because we are all better off if we are able to share data and can innovate based on those data, can create new solutions, new technologies, and then make sure that everyone can access them on different terms. Some need to pay much more than others because we have different purchasing power, but there is no agreement on that. And that I'm really concerned that the next pandemic will not be able to address this quickly, because we actually share data fairly quickly in the COVID-19 pandemic, and we were able to develop vaccines. Now, with a more transactional approach, individual countries will sit on the data, and we say we will share if you can guarantee that we will get the benefits of the technology that your companies are developing. And if all do that, we will lose a couple of years instead of actually doing something quickly.
Our next panel, we should talk. It's not the next panel, but we should talk about that. That's a really good point. Az on the ground, take us back to trust and trusting data. We were just talking about protecting data, territoriality, tariffs on data. I don't know if Jan Arne was going there. What about trusting data on the ground in communities that need it and require it?
First of all, it's a trust in general. We have made so many promises over the years. We broke them, and there was no accountability. But also, we forget that communities remember. So we promised primary health care for all. Where are we now today? We had a decade of water, an Alma-Ata declaration in the 70s, where we promised, health for all by the year 2000. We're at 2025. We promised, recently that people don't worry, we'll bring you vaccines because we are putting systems in place. We promised them, that, despite, all the other conflicts and then crises in the world, you will not be forgotten. But then in Ukraine changed, the whole dynamic. I mean, all of that is eroding trust. And I think to erode it is so easy, to rebuild it is so difficult. Now, in order to rebuild it, it needs a continuous engagement. Building trust in the middle of a crisis is almost impossible. Those who were there before, are there during, and are after? could also deliver on the promises, that are being made. And that is the reason why, there is very important, to have the local actors, to work with, to tap into their expertise and their wisdom, all the way, from surveillance, to contact tracing or to a collection of sample. If there is no trust, none of that, will happen. And I think there are many relays, in those communities, and then the lessons, we can learn. But always remember one thing: when you make a promise, let's not break it.
That is a vow that I think we should all keep. And I want to thank our panel. We're out of time. I could keep going, but this has been really instructive. Thank you so much, Az, for that final thought. When you make a promise, let's keep it. Yarn Arna Rodigan, Celeste Saulo, Asi, thank you so much for joining us.
Thank you.
Please welcome the Municipal Health Department of Rio de Janeiro's Superintendent of Health Surveillance, Gislauni Mateus, and C40 City's Managing Director of Climate Solutions and Networks, Cassie Sutherland, for a conversation with FP Senior Vice President of Research, Dr. Maisha Alam.
Hi, everybody. Thank you again for being here and for joining us online. As you've heard over the course of today's programs, we've been talking a lot about climate and health and the relationship between the two. And I'm excited to have an opportunity to build upon those conversations by focusing on the role of cities in innovating and problem solving. Before we dive in, just a little housekeeping note. We may, at points during this discussion, require simultaneous translation. And if that's the case, there are devices on your chairs if you're in the room, and they should already be set to English. You may have to turn them on. Some may be on, some may be off. So hopefully that's very easy to do. If you require translation, the translation, if it does happen or if it is required, will be from Portuguese to English. And again, that'll be simultaneous. If you require it for any reason in the opposite direction, from English to Portuguese, please go to the booth at the back of the room and there'll be somebody who'll be able to help you with that setting. With that out of the way, thank you again to Cassie and Gislauni. I'm so excited to have this conversation with you. Gislauni, I'd love to start with you. You have done something really remarkable in Rio that I think a lot of cities and a lot of communities can learn from, which is to find a targeted solution to heat, something that people all over the world are struggling with, right? As temperatures rise and the weather is hotter. And so tell us a little bit about Rio's heat protocol, which is the first of its kind in Latin America. What drove the city to prioritize this? What was the process for developing it? And what difference has it made to your communities?
Hello, everyone. Oops. Yeah, let's start. Hello, everyone. It's a pleasure to be here with you, sharing its heat protocol for extreme heat. So Rio is the second largest city in Brazil, with more than 6 million people. And when people think about Rio, maybe people think this is an amazing city with beautiful beaches and an urban forest. But people think about heat and favelas and vulnerable areas and inequality too. So heat has always been part of the city. But after a strong heat wave in November 2023, it became clear that heat is not only a characteristic of the city, but a climate risk, a danger. The city already has mitigation and sustainability plans, but climate change is real, and these impacts are happening now. So that is why cities also need adaptation plans to protect people and save lives. So besides mitigation, we need conscious plans to reduce risks, communicate clearly, and protect lives. Rio has always been known for its heat, but in November 2023, a severe heat wave changed this perception. During a big concert in Rio, a 19-year-old girl died from heat exhaustion. That same day, the heat index reached 49 degrees Celsius in the city for more than 8 hours in one day above 40 degrees Celsius. In total, 151 elderly people also died from heat-related causes. This tragic event pushed to Rio, the city of Rio, to create a protocol for extreme heat with contingency measures for heat waves. The mayors in person, the mayor's office, along with the health department, the environment and climate department, and operations and resilience center of the city, lead to creation of Rio's heat protocol. The main challenge was to understand who is most affected by heat. What temperature or heat index levels are truly dangerous, because Rio has always been heat city. So what metrics and triggers should start actions? What actions been starting? So the Epidemiological Intelligence Center analyzed climate data and health records data. Not only mortality, but mortality and visits and emergencies and primary care units in the Rio de Janeiro. The study analyzed more than 12 years of climate and mortality data in Rio, showing a clear link between extreme heat and excess deaths. Using the heat index to demonstrate that both intensity and duration matter. 4 hours above 49 degrees Celsius, 40 degrees Celsius, or just 2 hours above 44 degrees Celsius already increasing mortality by 50% in cases related to heat. Based on this, Rio developed a 5-level heat protocol. So how this protocol works? Sorry. As you can see, my English is not very well, so I use my notes.
It's better than all of our Portuguese.
Yeah, exactly. Thank you. So how does the protocol work in practice? The protocol works as a smart and dynamic system that keeps Rio de Janeiro one step ahead on extreme heat risks. So it combines real-time climate data from 16 meteorological stations in the city with health information from 239 primary care units and 65 emergency units, public units in the city. All this feeds in the heat dashboard. It's a tool, the heat dashboard, with predictive models monitored by the Epidemiological Center and Resilience Center. The dashboard constantly analyzes the data, classifies the city into one of 5 levels of heat, and issues alerts. And level 4 or 5 are started. The protocol activates a strong and coordinated response. Like open cooling centers, strange health teams.
Very practical.
Yes, it's very practical. It's not about monitoring, but action.
Yeah, absolutely. And it's so, first of all, thank you for walking us through how you came to the realization that this was urgent. And, you know, one of the things I'm really struck by as I listen to you speak is heat is a killer, and we need to acknowledge that, right? It costs lives, and there are certain parts of a population that are going to be more vulnerable, particularly the elderly, as you said. But also, you know, I'm struck by how important it is to have that kind of comprehensive data and monitoring, and to develop those practical actions, as you said, drawing on that data and monitoring. And so, Cassie, I'd love to bring you into the conversation next. You know, as we're listening to Ghislaine explain how it's worked in Rio, tell us a little bit about how your C40 cities network is working to accelerate the adoption of effective heat adaptation strategies elsewhere. The challenges that she shared are hardly unique to Rio. So how are you working through your network to bring these types of heat adaptation strategies and solutions to cities across the world?
Yeah, sure, and thanks for having me. And just for anybody who doesn't know, C40 Cities is a network of nearly 100 of the world's largest cities, where the mayors of those cities have committed to take high, ambitious action on climate change, on mitigation and adaptation. We were once 40 cities. That's why we're called C40. We're not anymore. We're nearly 100. We couldn't be rebranding all the time. The main thing I think that's right at the heart of a network like C40 is being able to share solutions and ideas across cities. So the principle of why the network was created is there's more that unites cities than divides them. And in fact, going after Ghislani here is perfect, because what Rio have done has been informed by what other cities around the world have done, and also will now inspire a whole other group of cities. And so we really, our function is to be able to share those ideas and then support cities to implement them. I think what we're really seeing over the last few years is, as you mentioned, this huge increase in demand for support on tackling extreme heat. As Ghislani say, people have always known Rio to be hot, but not this hot. Not 49 degrees hot, not for a prolonged period of time, for 8 hours of over 40 degrees. There are so few cities that are set up for this. And what I now see is that cities all around the world are facing these extremes of their temperatures that they weren't before. And that's where infrastructure starts to collapse, systems start to collapse, healthcare becomes overwhelmed, and, as you mentioned, the most vulnerable are therefore dying, and that's elderly, young people, people with pre-existing health conditions, outdoor workers, people who are working outside. So the demand is high. I think what networks like C40 can do, and other city networks, is really help put cities on the road to putting in some of these practical applications. So we can be a broker for some of the data that's needed. How do you start to use some global data sets to inform cities and give them the baseline information? You'll still need expert knowledge on the ground to be able to inform the exact action, but we can start to work on that. And so we're producing a heat insights tool that helps granular kind of monitoring of heat and the distribution across the cities, because that varies as well. The other thing that we do at C40 is provide different pieces of assistance to cities to deliver their actions. I'll just give a couple of examples on that in a second. But also supporting cities to do a full risk assessment across all of the hazards that they're facing, and how they can start to then have evidence-based and informed decisions. And so maybe a practical example that we're supporting at the moment is we're supporting Rio actually on translating some of that data into action, particularly around kind of cool routes along the city. So how do you start to look at particular areas of high heat exposure, maybe where lots of children are also traveling as well, children going to school or moving around the city, and start to put in, either cooling stations or infrastructure that's going to make that a more possible and accessible route.
As I was listening to you speak, a couple of things struck me that I wanted to pick up on. You talked about the role of infrastructure, and when infrastructure that's been around for decades is no longer fit for purpose in many ways, and no longer meets the challenges in terms of heat adaptation. It strikes me how important it is to think about the role of the built environment in finding solutions to these challenges. And so, yes, we need climate scientists. Yes, we need public health experts, but we also need engineers, urban planners, an ecosystem of actors. The other thing, and at the outset of your comments, you alluded to this, which is this is by no means a challenge that's exclusive to the global South or certain regions. We've seen in the news everything from London to Paris to plenty of other places that are really, really struggling because of those extreme temperatures. And so, Ghislani, to go back to you for a moment, you led this effort, you've implemented it. If you were to pick 2 or 3 lessons learned from Rio's experience that you would want other cities to be aware of, right? Thanks to your experience. To be.
It's a good question, because the RIO protocol isn't just a local solution, but a model that inspiring other cities, can inspire other cities. The biggest lesson from RIO, I think, is simple. Proactive preparation save lives. And the second, combine solid data with a real-time and predictive models with health and climate save lives too. But data, only data, do not do anything. So the third lesson is protocols for action when people need this action. So RIO turning tragedy into action and develop a protocol based on science, technology, but action. Action, not only health department, on environment and core resilience department, but RIO turning heat in all the city. Now, if you go, and you all are invited to be in RIO, you are which heat level the city is now, and the actions and take prevention measures that people have done. So the inspiration of RIO is that resilience can be built step by step to protect and save lives.
Fantastic. Yeah, I love that. And thank you for breaking those down. So to recap, proactive preparation, data and monitoring informed strategies, and then ultimately deploy tools for concrete action, right? And step by step. I'd love to ask a question to both of you, which is, we have COP30 coming up very soon, of course, in Brazil as well. Folks from all over the world are here at UNGA looking for solutions, talking about financing, the need for partnerships. And if each of you could issue a call to action to policymakers, investors, local leaders, what are the one or two kind of most critical messages you would want leaders to know and to take forward in order to really get real about heat? You know, heat as an environmental challenge, as a health challenge. So Cassie, I'll go to you first, and then Ghislaine give you the final word.
Yeah, sure. And I think my first one is have a look who's doing it well and copy them. So I think, you know, we've heard RIO, don't start from a blank sheet of paper, have a look. And I think in terms of heat, one of the things that RIO has done very, very successfully is bring together the departments within a city to take action. There is actually no heat department in most cities. So you need to work across environment, climate, health, transport, logistics, politics. So that's been really well done in RIO with lots of their kind of response work. But building on that, and then putting in place the immediate support. So we're in the crisis, we're in the heat wave. How do you help people prevent deaths, but also prevention on a medium to long term? So how are we looking about building more green infrastructure into the city, cooling the buildings with sustainable cooling options? And so I'll leave you with those are my kind of very practical suggestions for policymakers. Bring those departments together and then look across those two time horizons of immediate and longer term. And on the copying ideas, you should copy RIO, definitely. Speak to Ghislaine, she'll tell you how to do it. You should copy the city of Freetown in Sierra Leone that's provided covers over all of their markets so that people can still go to work and serve the communities. You should copy the city of Medellin, where they put in place green corridors that span out from the cities instead of new road infrastructure, providing an overall cooling effect. You should copy the city of Phoenix, that's done cool pavements everywhere and reduces the temperature on certain streets by 6 or 7 degrees Celsius at the hottest part of the day. I could go on, but those are the kind of things that we should be copying.
That's amazing. Thank you. Yeah, those are great examples. Ghislaine.
The RIO showed this challenge for it. RIO has now a heat protocol, but it's not enough. Cities are in the front line of the impacts of climate change. So in the COP, the governments like it as representative of local governments. Cities need resources, financing, and universal coverage for health systems. So work together with transport education. So this is the message. We need early warning systems and a protocol with concrete actions for protect lives.
Fantastic. Well, thank you. Thank you to both of you for those. Yes, absolutely. Excellent ideas and excellent strategies. And Ghislaine, you said something in particular that I don't want us to lose sight of, which is the importance of financing. And so philanthropy has a role to play in this. Those who, finance ministries, you name it, we need to make sure there are resources behind these plans and strategies. Thank you, Ghislaine. Thank you, Cassie, for what you're doing and for sharing your insights today. For our audience who are in person, there will be folks at the end of the rows to collect the simultaneous translation devices. If you would be so kind to just pass them along to the end of the rows, that would be great. Thank you again.
Please now welcome AstraZeneca Executive Vice President of Global Operations and IT and Chief Sustainability Officer, Pam Chang, for a conversation with journalist Maggie Lake.
Hi, everyone. I hope you've enjoyed the program so far. I'm going to give you 1 second to get settled. I know we're all moving around. Hi to everyone who's watching on live stream. There have been so many great conversations. Pam, it's so good to see you again this year.
Good to see you again.
I love coming out of a conversation that was really practical about examples on the ground, both in terms of challenges that we're facing, but also solutions that are being put in place. And we heard in the case of Rio, it's very much out of necessity. But sort of let's pull the lens back a little bit. And can you talk to us about why it's so important to take an integrated approach to climate when it comes to NCDs?
Oh, absolutely. So for those of you not in the field, NCD stands for non-communicable disease. So effectively everything other than infectious disease, things that you can carry on from person to person. So I think I'd like to take a step back. First of all, it's great to be doing this with you again this year. We should take a step back and understand there's an absolute interdependency between planet health and human health. If you look at the impact of climate crisis, 13 million people die each year. We talked about heat in the session before us. 13 million people die each year from pollution and extreme heat alone. So the climate crisis absolutely exacerbates the NCDs, right? So I think, one of the things that AstraZeneca is really working on with policymakers and with communities is this notion of early action on NCDs. So I'll give you one specific example, and I don't know if you know this scary fact. 1 out of 10 people globally has some form of kidney disease. It's scary. And late stage of kidney disease means dialysis, something pretty awful for the patient, for the communities, for the families, and for the healthcare system. And we also know, we've done studies that show that early intervention of kidney diseases means delaying that dialysis and perhaps not even have to go through that. So it's better for the patient, better for the environment, better for the payer system and the healthcare system. So just a fun fact here. It's not a fun fact, but it's an interesting fact. Each year, dialysis uses 169 billion liters of water. It generates 1 billion kilos of waste. So just think about that. So if we can really avoid or defer or delay dialysis for kidney patients, for example, chronic kidney disease patients, I mean, that's just win-win-win.
And that's just one example.
That's just one
And
example.
I'm sure we could do the math on a lot of others.
Absolutely.
So, and the issue of early action has come up throughout. What strategies can help health systems withstand the impact of climate, get ready for that, build that resistance? We heard them talk about the need for early action in Rio. What can we do to improve health systems so that we're not reacting and we are getting in front of it?
That's a great question. So, I mean, from a global economy perspective, NCDs adds about $2 trillion a year burden to the health systems. They forecast that between 2010 and 2030, in a 20-year period, NCDs adds $47 trillion of burden to health systems already under stressed. So the notion of early action, I think, we really need to transform from sick care in many parts of the world to health care. And we hear that a lot, but we need practical actions that can be implemented, that can be actioned, right? So one of the things is training health staff to be able to diagnose disease early, screening technologies and tools to make sure that we catch these diseases early and we can treat the patients early. And don't forget about prevention. The best form of treatment is prevention because you don't need any of these interventions if you can prevent these diseases from happening. So I think this notion of prevention, early detection, early treatment, which drives better patient outcomes. So I think this is one of the things that what healthcare systems around the world really should be focusing on. Longer term, it's better for the health system.
How can we, I think of a company like yours, and you're working so hard on solutions, you have the data, you have technology, you're pushing into the areas of innovation. How can policymakers, healthcare operators work more closely with industry leaders to try to get this sort of cohesive policy integration? Well, what needs to happen?
I think this is key. I mean, whether it's NCDs or climate crisis, there's no one entity, be it public or private, can do this alone. So it really is about harnessing public-private partnerships, a lot of it, that can be scaled. So I think best through examples. So I think when it comes to public-private partnerships, it can be done in two levels. One is at the strategic level around policy making, and then the second around what I call the practical level, where you can actually have things that you can implement and scale. So I'll give you one example of each, if I can.
Please.
So there's one effort called the PHSSR. So this is effectively talking about healthcare system sustainability and resilience. And AstraZeneca co-founded this with London School of Economics and World Economic Forum a few years back. And the sole purpose of that is to generate evidence and data to help the policymakers around the world to make the right policies, set the right guidelines and set the right policies. And I think to date, we have generated the largest body of evidence thus far. And many of these evidence and data and recommendations are already being integrated and incorporated into policies around the world. So that's one specific example. The second example around practical level, we have an initiative going on since 2014 called Healthy Heart Africa. And the intent at the time was we need to diagnose early the hypertension issues. So we work with the African government, and today we've trained 12,000 healthcare workers on the ability, the skill set required to do diagnostics and so on and so forth. We screen 67 million people. These are not patients, these are healthy people, 67 million people, and we found 12 million of them has hypertension. So think about the cause and effect of that, right? So for these 12 million people, they no longer run the risk of stroke, heart attacks, and issues because they didn't even know they have hypertension. And today, you can control hypertension relatively easily and affordably. So I think these are the examples where, and now we are moving from hypertension to CKD, chronic kidney disease, precisely because we know there's a need for that.
And I think these are amazing examples because we're often talk about the scarcity of resources. Absolutely. And we're hearing how much need there is. But when you can save that much money, the strain that you take away from healthcare budgets for countries who need that money for other things is critical. Is this scalable? I mean, we just heard before, if you see an example that's working, take it. Don't start from a blank page. Are these programs that you're working on scalable?
Absolutely. I think there's very few magic silver bullets in life that will fix everything at one time, right? So it really is about the collection of actions. You know, one company at a time, one entity at a time, one government at a time, because when people see it works, we can replicate. And it's some of these, this whole notion, for example, of prevention, early detection, early treatment, better patient outcome, more affordability for the government. It's kind of obvious, but truth to the matter is, it's not so obvious when policymakers are trying to make the right decisions around the guidelines and policies. So it's important to put data and science. We're a scientific company, so it's important to put evidence and data and insights behind it so that it's with clear business case, clear data, clear insights, clear evidence in terms of what can be scaled, what can be done. Because we know if we stick to this, over time, it's better off for the system.
Yeah, and that business case part of it is important as well. Absolutely. Pam, we're out of time, but thank you so much, and thank you for the good work you're doing. We appreciate it.
Thank you so much. Thank
you. Next, please welcome Bupa Chief Sustainability and People Officer, Nigel Sullivan. Rockefeller Foundation Vice President for the Health Initiative, Manisha Bingji, and Director of Clinical Innovation for the Health Tech Hub at Cornell Tech's Jacobs Institute, Dr. Chetan Sarabu, for a conversation with FP's Dr. Maisha Alam.
Hello again, and thank you to our esteemed panelists for joining us. Continuing to build on the recurring and really important theme about climate and health, I'm really excited to have this conversation on future-proofing healthcare, and specifically focusing on what are the innovations, adaptation strategies, solutions that are already helping to make healthcare more climate resilient, climate responsive. So thank you to all of you for joining us today. Nigel, I'd love to start with you. We know that the impacts of climate change on health are becoming increasingly clear, as is the need to make healthcare more climate resilient and environmentally sustainable. And you all at Bupa have been thinking about this for quite some time, and not just thinking about it, but putting things into action. So tell us a little bit about how can health systems integrate climate-smart innovations into core strategies, and what are the opportunities that you see to reduce emissions, clean up supply chains, strengthen resilience across key areas, whether that's energy, infrastructure, digital?
Thank you. Hi, everybody. Just to give you a quick overview, because some of you will have heard of Bupa, some of you, particularly in the States, you might not have. We're an international healthcare company. We look after 60 million people. We have a network of 50,000 doctors. We're in many countries overseas. We've been around since 1947. I think that to get to one of the points in your question, I think one of the innovations we've seen that can have a really fantastic impact, not only on the environment, but also on individuals and patients, is digital, and we've seen a massive sort of increase in that in our business, and we continue to see that happening. So one of the products that we sort of are brands that we roll out globally is called Lua, and it's a digital healthcare solution. It's got the things that you would expect in terms of symptom checking and doctor on the phone and e-pharmacy, but also it's more heading towards personalized healthcare plans. Now, before the pandemic, like we were frankly struggling to get the thing moving. We've now got over 8 million people on that platform across over 100 countries, and we've something like 14,000 clinicians, engaged in it. it's having an enormous impact, and we're finding that it not only does it increase participation and personalisation and prevention and prediction of healthcare needs and gives the customer a bit more insight into their own health. Its impact on the environment is better, as well as engaging. So those innovations, I think we've got a retinal internal retinal scanning capability in Australia, where we've put 10 million customers through that already, and we continue to roll out our genomics program as well, which is currently a pilot of 11,000 people across a couple of countries, but we're going to scale that to 250,000 people over the next few years. And the link between that and digital and this whole push towards prevention is, and I just listened to the last speaker, it is a win-win. It's a win-win for the patient, for the health system, and also we're a commercial organisation. It's a win-win for us as well. So I think the digital piece and digital health, as it gets more and more sophisticated and easier to access, I think is a major innovation for us and a major impact on the environment.
That's really interesting, and as I'm listening to you speak and some of the examples you highlighted, the emphasis on digital really comes through, and of course the role of emerging technologies. And Chetan, I'd love to bring you into the conversation next, because this is really where your work is situated. And so, as Nigel was alluding to, there's a need to balance efficiency and innovation when it comes to thinking about also the carbon footprint of digital health tools, right? So tell us a little bit, from your vantage point and the work that you're doing, what role can AI and other emerging technologies play when it comes to, on the one hand, improving care, and on the other hand, minimizing environmental costs? Are there any concrete examples you can share about what that looks like in action?
Yeah, so really a great pleasure and honor to be here with all of you today. So I am a primary care pediatrician. I'm also board certified in clinical informatics, which is a new subspecialty of medicine, training doctors to think about and understand technology from digital health to the latest in AI. And originally, actually, prior to going to medical school, I'm also trained as a landscape architect. So trying to connecting the dots between environment, health, and technology. And this all really came together for me when I was working as a primary care pediatrician in the Bay Area in 2020. It was the midst of the COVID pandemic. Children were home, isolated, terrible mental health crisis that we were facing. And in the San Francisco Bay Area, in the middle of 2020, due to the wildfires in the area, we had the worst air quality in the world for weeks at a time. There was almost a month where the AQI was over 100, over 150, which was just unhealthy for anyone to be outside, but particularly children with asthma. And then you couldn't gather indoors because of COVID. And so it was a really difficult time. But as I was sitting in clinic, and I worked at a federally qualified health center, taking care of a lot of children who are recent immigrants from Central America, I noticed that when I pulled up their electronic medical record information to understand their health history, looking at how many times their asthma was triggered, how many times they had to refill their inhaler, the key piece of data that was missing was the air quality they were exposed to. In the electronic health record, when we're sitting in that room, it's not there. And we heard from Celeste at the World Meteorological Organization, there's so much work going on to collect environmental data. And on all of our phones, we have that air quality information, but it is not making its way over to the clinical world. And so that's a lot of what I think about. How do we bring environmental data to the front lines of care? But then, thinking about that question of what can AI do, I think first we need to bring the data in. But then AI has a lot of promise because it can actually help analyze all of that data and help make sense of it. Most doctors aren't necessarily trained in understanding what to do with regards to wildfire smoke or heat waves. We're making progress, but we need to be able to actually have rapid ways of analyzing all of that data and providing actionable insights in terms of what you should be doing as a clinician at the point of care. And so I think that's the promise of AI and data and clinical care, really at the health and climate intersection. But we also really have to think about the environmental footprint of it, and happy to go into it in a little bit. But just to hint at that, a team I led recently of researchers at Stanford, Cornell, where I'm based now at Cornell Tech in Roosevelt Island, as well as Harvard and Berkeley, we've developed this new framework called Sustainably Advancing Health AI, and it's really a call to healthcare leaders to look at the promise of AI, but to understand its environmental impact. And small decisions that you make, whether you're using, the latest, greatest AI model versus last year's model, there may be a 10x difference in the overall emissions, but you may only get slightly more percentage accuracy in what you're trying to do. So what we're really calling for is saying, we know AI will make an important difference in healthcare, particularly at the climate and health intersection, but small decisions in which model you're using, how you're tuning that application, what data centers are powering that, have tremendous differences in the overall trajectory, and it's important for healthcare leaders to balance both of those together.
Absolutely. No, that's really fascinating. And again, I appreciate you not just walking us through your fascinating background, but also these different pieces and how they fit together. And one of the things that you said that really strikes me is, and you used the example of AQI, right? This is data that already exists, that's being collected en masse, but is it reaching the people who need it in order to adapt their approaches to care, and how do we bridge that gap is just as important as some of the other kind of things we've been talking about, new developments, new strategies, and so forth. As I'm listening to both of you speak, Nigel and Chetan, another thing that really comes to the fore of my mind is, let's not lose sight of fundamentally what we're talking about. What we're talking about is people's lives and livelihoods. Are people going to live? Are they going to die? Are they going to have healthy lives and hopefully live long and healthy lives, or not? And that has a lot to do with thinking about access to care and addressing what are persistent inequities. And this is something that, of course, the Rockefeller Foundation is keenly focused on, not only making healthcare more climate resilient and environmentally sustainable, but also ultimately ending unmet needs and making sure that communities, especially in climate vulnerable settings, are getting access to, whether it's these technological innovations or the data or whatever it is. And so, Manisha, I'd love to turn to you next and ask you a little bit about how you all are thinking about this at the foundation, and more specifically, how can some of these innovations be scaled equitably, sustainably, across low resource and high resource settings? Tell us a little bit about how you're approaching that work.
No, happy to. And, you heard a little bit from our Senior Vice President, Naveen Rao, earlier today. And one of the things about being at a foundation that's 110 years old is this persistent history and this optimism that human ingenuity can and will transcend a number of these challenges that we face today. And I think with the extraordinary times that we live in today, we are seeing and we need extraordinary leadership. And that leadership comes from multiple dimensions. We saw even today the launch of the Belém Health Action Plan, and that's leadership coming from Brazil's COP30 presidency. We met Professor Saulo at this panel just a while ago, really rethinking how WMO, a multilateral agency, changes how it is fit for purpose in the 21st century. And Professor Saulo and the WMO is a partner for the Rockefeller Foundation, and we are working with them to develop what is called climate services for health, and bringing that to the last mile in the countries where vulnerable populations are most at risk from climate threats. That does not happen overnight. There's intention and there's action. And for that kind of change, we need different capabilities, different partnerships, and maybe even a fundamental shift in mindsets. And we have the privilege of seeing that across the partners and the portfolio of programs and grantees that we work with, who are, at the end of the day, our foot soldiers on the ground. They are our inspiration, and we want to elevate both their leadership as well as the innovations they bring to the table. So I'll give 3 examples. I think the first, it was great, you just met her, Gislani from Rio. And through the C40 Cities Alliance, we were able to work with Gislani to really strengthen her ability to provide heat action plans for the city of Rio. And you ask about how to scale that, and that's where Cassie's work in C40 really comes in, because who do we learn from? We learn from our peers. So cities are going to learn from each other. Countries learn from each other. So how do we work with exemplars within these communities, really build them up as proof points, bring the evidence base, and create the learning platform for others to work with. The second example is, more outside the health space. In Bangladesh, where agriculture workers are most at risk of heat, and these are largely women. This is not a choice. You can't sit in the shade and wait out your livelihood. You have to work in the fields. That's 45% of the country's economy. The Ministry of Agriculture was most interested in protecting the lives and the health of their agriculture extension workers. They went to the Ministry of Health. This is a different model that we are seeing, where to protect economies, different sectors are really thinking about health. So we are pushing the boundaries of what it means to deliver health from the healthcare system upstream to other adjacent sectors. And finally, we need to find new ways to pay for this.
Yes.
I think, it's great to have innovations. They'll only scale if they have value, number one, and number two, if you have financial sustainability. And this is where innovation also comes in, is we need to find new ways of modeling, new business models, in fact, to approach financing for these solutions. And I think we're looking at adaptation financing and climate financing as a real avenue. There are 3 things that we are learning. First is health is a critical part of adaptation, which is why we are seeing Green Climate Fund and other climate financing forum or funds really supporting or wanting to support health. The second is, with the advent of data and the translation of that data into risk models, we are having a better understanding of what the risk means, both from a hyperlocal standpoint as well as from a timescale standpoint. That allows us to create new approaches and new financing frameworks to manage risk, to mitigate risk, and to incentivize adaptation and behavioral changes. So we are still looking at these approaches to see what is that market and think forward into what is possible, not just what is.
Yeah, I love that. And to your point also about what's the value proposition here, right? But also to pick up on another thing, I loved the 3 examples that you shared, and to connect the first one, the cities learning from each other, and the second one about Bangladesh and the Ministry of Agriculture. As I'm listening to you speak, it strikes me that, yes, absolutely, to your point about the agricultural sector, but also if you think, for example, in Bangladesh and many other places, brick making, which often happens in urban settings, primarily by women, right? What can be learned and transferred subnationally as well, right, and adapted, especially considering urbanization trends. So thank you for that. When we talk about equity and access, let's be clear that that responsibility falls not only on philanthropic institutions, nonprofits, or even the public sector, but industry and the private sector has a really important role to play. And I know, Nigel, this is again something that you all at Bupa care about and have focused on, which is bringing these innovations, whether it's smart technologies or some of the other adaptations you've mentioned, to under-resourced settings, whether that's in the global south, global north, really anywhere. We know inequities exist in every society. Tell us a little bit about how you're addressing that.
Well, it's quite a topic in the private health sector, the debate between affordability and accessibility of healthcare. And, I think we would broadly come down that affordability's, broadly speaking, the public systems need to do that. Accessibility, though, we think we have a part to play, and I think there's an intersection between the two. So this BLUA thing that I mentioned at the beginning, we aim to roll that out to around about 20 million people over the next 3 years. And to give you an example, we've got some price points. I'll try and do the dollar thing versus pound, UK pound, but roughly speaking, a really capable, application, something that you wouldn't get sort of generally from the App Store. Something that's really rich, really valuable, really unique. Between $20-30 a month, kind of price point. And we've done this in one particular customer en masse in the UK for a corporate customer, and it's really popular. So we think there's something in this in terms of it is a commercial product, but it's something that we think could be affordable for many more people, and maybe could be a freemium product as well, as well. So it's quite early days for us with this. We've just nailed the tech and nailed the access, but we think the applicability of this across multiple health systems could be really good.
That's great. That's great. Any examples, Chetan, you want to share in terms of that issue of how do we make sure that some of the technological innovations that you and your colleagues are working on are reaching under-resourced settings and underserved communities?
Yeah, so I think we're at this time of great technological transformation, primarily because of AI and what it means in terms of the democratization of health information. I was actually invited a few months back to speak at a forum in the Philippines about the potential of AI to reach and expand the accessibility of specialist healthcare knowledge in some of the remote islands. And I think we're seeing this shift to happening with information being really held by doctors, healthcare systems, to being more democratic. Actually, a quick show of hands, how many people in this audience have used ChatGPT or other AI tools to ask a personal health question or health question for a family member, loved one? Okay, we're seeing maybe 15-20%. I think that's growing, right? We're at this time of great transformation in terms of